Good afternoon, everybody. Thank you for joining us today. This is Danielle Wiltsey. I am with Care Design. I'm the Director of Individual, Family, and Advocate Supports. And today we're going to have a discussion with a collaboration with Care Design and PHP and Dr. Stephen Deutsch, who's the PHP Chief Medical Officer, doing a discussion around making sense of COVID-19 vaccine. I just want to go over some housekeeping items before we get started, but I do want to thank everybody for joining us today. We really appreciate it. I hope everybody's having a nice afternoon. I had mentioned in our member and family meeting, it is sunny up here in Capitol, a little chilly, but sunny. All right, so Carlene, can you move to the next slide, please? Awesome, thank you. So I'm just going to go through some housekeeping items. As I mentioned, I want to welcome all Care Design and PHP member and families to this meeting. I want to let everybody know this online meeting will be video recorded and it will be uploaded to the Care Design and Partners Health Plan website for public viewing. I do want to mention we did have a session yesterday morning at 11. And that video has already been uploaded to the Care Design website. So if there are any members of families that you know of that are not able to attend, we do have the recording up from yesterday, and we are recording today's session as well. For those of you who turn your computer camera on and or microphone and speak during the presentation, please know that you will be recorded. When you completed the online registration process, you had agreed to participating in the online recording, so please do not turn your camera or microphone on if you do not wish to be recorded. I do ask that people remain muted just because I could hear right now that there's some background noise. Just gonna, all right. Also, as I mentioned, you can use, it is being recorded, but you can also use the online chat function. So for those of you that are on video, you have the chat box that you can utilize. I do see that there are some people that are on this meeting through the phone as well. So what we're going to do is we're going to go through the presentation and discussion, and then we will have time for questions and answers. And at that time, I do plan on alternating between the phone and the chat as well. And if for some reason we are not able to get through all the questions that are being asked, we will take the information that's in the chat, as well as you can reach out to myself. You'll see my information there. You can reach out to my email, or you can email memberfeedback@caredesignny.org. And what we can do is for those questions that if we do not get to, we will definitely follow up and give a response to the group and put that on the website as well. So I just want to mention at that time, like I said, I will be monitoring the chat and alternating between the phone and the video just so that we can make sure everybody is heard. Also, just some mindful housekeeping tips. We want to be mindful of the time set for this meeting. We do have until 2 o'clock. We want to make sure that we listen to each other's statements. I want to make sure that one person speaks at a time so that everybody can be heard. And as I mentioned, please ensure your phone or computer is on mute. For those on phone, is *6 to mute and *6 to unmute. And those on the computer, you can hover over your mic to mute or unmute, but we just want to make sure we're limiting that background noise. And as I mentioned, you are welcome to type the questions into the chat. And I do ask that, oh, I do hear some feedback. I do ask that if you have any questions that may be specific to a member, that you could reach out to myself outside of this meeting or to the care manager, just because we want to be mindful of HIPAA and confidentiality during this meeting. All right, and then I'm just going to give some information in regards to our presenter, Dr. Stephen Deutsch. Dr. Stephen Deutsch is a PHP Chief Medical Officer. He is a board-certified orthopedic surgeon trained at Columbia and Harvard, where he served as chief resident at the Massachusetts General Hospital and on the faculty of Harvard University. He was a member of Brown University Faculty of Medicine, where he taught and practiced for 20 years. Areas of focus include spine and scoliosis, cerebral palsy, myodysplasia, and pediatric orthopedics. He authored more than 40 scientific papers and exhibits. He has served as chief medical officer for a telehealth technology company, a company that managed high-risk health plan members, and for the largest PACE program in the country, where he built and integrated programs for medical and care management, palliative care, transitional care, behavioral health, and clinical pharmacy management. Dr. Deutsch has given talks in numerous venues, including the Harvard Business School and the National Data Forum on multiple topics, including quantitative bone scanning, disease management, and the use of data. So at this time, I'm going to turn the discussion over to Dr. Deutsch. Thank you, Dr. Deutsch, for joining us today.
Good afternoon, everybody, and thanks, Danielle. Appreciate the introduction. I'm going to spend the first part of this talk very briefly talking about some vaccine facts, which I think are important for everybody to have as a baseline of understanding where we are and where we might be going. Let's talk about vaccines in general. They date back years. There are some recordings around the 11th century, and in the 1500s, the 16th century, about vaccinations using a technique called variolation, and that had to do with smallpox pustules. Vaccines really came into their own in the late 1700s when Edward Jenner developed a technique for vaccinating against smallpox. And in essence, you might say that vaccines in general are our most potent and important public health tool and have really changed the world in terms of disease. They've eradicated a number of diseases which were deadly through the years, such as smallpox, polio, and measles. I just want to raise one issue, and that is in the mid-90s, or actually a little bit later, they got a bad name because somebody did a small study and equated the fact that MMR vaccines might lead to autism. That study has since been disproven and debunked about 6 times over, and actually the information was falsified, and the person who did that study eventually lost their license. So vaccines have no relation to causing disease. In fact, what are vaccines? And really what they are is a modification in some way of the virus that we give you that primes your body's immune system to make antibodies. So when the real virus comes along, which is much more severe and virulent, you can deal with it. The main goal of vaccinating somebody is to prevent the disease. However, you've heard the term herd immunity, and what that really means is if enough people are vaccinated, you get group protection, which means the virus doesn't have any host to jump from one person to another and eventually burns out. It's estimated for COVID that number is around 65% to 70% of the population. And quite frankly, that may include the world population, not just the US. It needs to be eradicated around the world. So what's with this warp speed? How did this vaccine get produced so quickly when I'm sure some of you remember reading about other vaccines which were in development for up to 10 years? And the bottom line is there are 3 parts to this. One is new technology, which is being used for vaccines for the first time. But in essence, the technology itself, which was used in other areas, was about 10 years old. The second part is funding. The federal government has put billions of dollars into this process. Normally, when a vaccine is developed, it usually is developed on a private basis. And then last but not least, volunteers. Once you do all of this, you need volunteers to see about the efficacy. And you're going to hear that term, or how effective the vaccine is. And in this case, there were numerous volunteers that stepped up, number one. And number two, we're still in the middle of the pandemic. You need disease to expose these people to see if the vaccine really works. So that's why, quote unquote, this has been developed so quickly.
Can I have the next slide, please? So let's talk about methods of development. And then after we talk about methods of development very briefly, we'll talk about the process of bringing this along clinically. There are the standard methods that I mentioned before, such as for polio and influenza. Those are inactivated vaccines. That means the virus is essentially killed, but particles from the virus are included. And in fact, it creates an immune response in your body. You can react to it and cause antibodies. Another method is attenuated, where you weaken the virus so it's not as virulent or severe. And then last but not least, the other standard technique has been viral protein. A lot of the viruses have a shell and they have a particular protein on it, and using that protein again to stimulate the process. What about the new technology? Well, the new technology works a little differently, and I put these pictures up so you could get an idea visually. We know the genetic sequence of these viruses. We learned that about a year ago. We also know within there is a gene which can create what we call messenger RNA, which creates the spike protein. The spikes in this picture are the red bars on the outside of the virus itself, outside the lipid coating of the virus. And those spikes are what attaches to a cell. The virus can't get into the cell until they attach. So what happens is we can, in fact, replicate the messenger RNA. We can package it. You can see that blue arrow goes to packaging it. And in this situation, it's a lipid nanoparticle, which surrounds it. It goes into your cell. And your cell then in the cytoplasm, there's two parts to a cell, the cytoplasm and the nucleus. The nucleus is where we have the DNA and the RNA. It goes into the cytoplasm and it begins to rebuild the spike proteins inside your cell. When this happens, your body reacts to it and creates antibodies against the spike protein. So please keep this in mind. This is not infectious. There's no virus being introduced with this vaccine into your body or into the cell. So this is how this process works. And there's one level of it, which is the Pfizer and Moderna vaccines, which are the ones that have been approved so far. And this is the mRNA and using the lipid nanoprotein. There is the Oxford AstraZeneca, which has been approved in the UK, and also J&J, which I'll talk about in a little bit. But in fact, they use a similar method, but they start out with DNA. The DNA then gets packaged in a safe virus, an adenovirus, which won't cause any problems. And that adenovirus is injected in, it goes into your body. The DNA goes into the nucleus of the cell this time rather than the cytoplasm. Then it creates a messenger RNA, which goes into the cytoplasm. And then you know the rest of the story in creating the spike proteins. So these are other methods, and there are other vaccines in the pipeline, which we'll talk about in a second, which are using some of the older methods. So the J&J just released data on phase 1 and phase 2A studies, which I'll talk about in a second, and it looks very promising. And in fact, it's possible that it may be approved in the next 2 weeks. And that one doesn't require a booster shot, whereas the Pfizer and Moderna do require a booster shot. The Pfizer at 3 weeks and the Moderna at 4 weeks. So what is this process, first of all, in terms of development? Okay. Well, you've heard about phase 1, phase 2, phase 3. What happens when you develop vaccines is you have preclinical testing. In the laboratory, we want to know if this process that's developed will kill the virus or prevent the virus from spreading. Once that's done, then you have phase 1, where you have a small number of people and you want to see what the dosing should be and is it safe, what are the side effects. Phase 2 is somewhat similar to phase 1, except it's expanded significantly. And then phase 3 is really a double-blind study where you give a part of the population a placebo, part vaccine. They get exposed, and depending on your protocols, you see how many people with the vaccine got COVID over a period of time and how many did not. With regard to side effects, vaccine history shows us that most side effects occur from a vaccine within 2 months at the longest. So that's why we've been able to speed this process up, at least getting 2 to 3 months worth of phase 3 information and data, but we can measure also during that time the antibody response and what we call the T and B cells response, which are antibody helpers. So with that in mind, are there other vaccines out there? Well, I kind of want you to see this, and you can see there are right now 64 vaccines in various phases. Again, 3 of which have been approved, at least in the UK and the United States. J&J is going to be coming along, but you can see you have other ones in Russia, and they're being used in other areas. Again, a lot of these are using the older techniques as opposed to the newer techniques, and there are about 85 in preclinical trials to see if, in fact, in animals they are effective. May I have the next slide? So what about the effectiveness and the safety of the vaccines that are currently approved? Well, both Pfizer and Moderna have been shown to be about 95% effective. What does that mean? It prevents disease, or it may lessen the severity of the disease, and it also means that about 5% of the people that get it don't respond to it. What we don't know is whether or not it prevents transmission. In other words, you get the vaccine, you're protected from the disease, it prevents it, but can you carry the virus in your nose or in your oral pathways, and can you give it to somebody else? We don't have enough data to know that yet. That's why you hear people saying, even though you have the vaccination, before things return to normal, number one, we probably need herd immunity so that you don't get transmission. And also, number two, we don't know who that 5% is. And we want to prevent transmission before we get herd immunity. So that's why even after the vaccine, for a period of time, masks, social distancing, good hand hygiene is still going to be in play. As far as the safety, or let me just go back 1 second. The AstraZeneca vaccine is probably about 72% effective, not as effective as the other two. There's been some issues about how the data was looked at. In one sense, maybe not as rigorous, in another sense, more rigorous. So that's a little bit in between. For the J&J vaccine, the 2A show that it's in the 90% range also so far. But we'll see once they expose their phase 3 data, which they probably will be doing in the next week or two. As far as safety goes, the big issue is an anaphylactic reaction, which is sort of a shock reaction. The body reacts very aggressively. It can close down your airways. It can even lead to death. How often does that occur? Well, the best way for me to illustrate that to you is by giving you some facts. And one fact is that for the influenza vaccine, this happens. And it happens in about 1.3 cases per million injections. For the coronavirus so far, it's happened in 11.1 cases per million injections. Because it happens, it's still, if it's treated properly, it can be resolved. There's been no deaths from the anaphylactic reactions. That's why everybody gets watched for 15 minutes. And if you give a history of having some significant reactions, you get watched for 30 minutes. And it needs to be in a facility where somebody can react if you have anaphylaxis with what we call epinephrine and antihistamines and steroids. And if so, you can usually resolve the situation fairly quickly. Are there any contraindications to the vaccine? The absolute contraindication thus far is a severe reaction to polyethylene glycol, PEG, or polysorbate, which is within the PEG. And in fact, those are common chemicals that actually are in laxatives, a lot of laxatives. So if you have a history of reaction to that, it's an absolute contraindication because that's part of the carrying package in the liponanoproteins. Questionable, even if you've had an allergic reaction to another vaccine or an injectable therapy, it's still felt at this time that you are a candidate for the vaccine. So other than the absolute, about everything goes if you have allergies to grass, if you have allergies to medications, etc. If you particularly haven't had a vigorous reaction, there's no contraindication. If you have, detail it to your provider and let them know, and they will still probably go ahead, but they will in fact be prepared to react if necessary. May I have the next slide, please? So what I'm going to do for the rest of my presentation is try and answer questions that I've anticipated, and give you some answers, and then certainly am willing to answer any other questions that I have left out. First of all, can the vaccine infect me with COVID? And the answer is no. As I said to you before, you're only getting the messenger RNA. It has nothing to do with the virus itself. It's taken out of the virus genetic coding. And so what's injected in is the RNA. It is not infection. I had COVID. Should I get the vaccine? The answer is yes. Most people feel you should get the vaccine. If you've had COVID, there's some talk about waiting 90 days, although I just recently checked on this again, and it's okay to get it sooner. The 90 days came from the fact that if you had COVID and were treated with monoclonal antibodies or plasma, you in fact should wait 90 days. Do I need to get tested before I get the vaccine? The answer is no. How long after I get the vaccine am I immune? Really good question. Pfizer is saying after the first dose, it's about 52%. Moderna goes from 52% up to 70 or 80%. It's a little bit hard to tell at this point. It goes back and forth. That's why you get a booster, because your body is working on creating, for the first round, those antibodies to the spike protein. The booster comes along, and now your body is reacting in terms of producing even more antibodies, which are proteins that go after the virus, but also the cells that are helpers, that what we call the B cells and the T cells that have a memory for all this, they get enhanced. So that's the booster shot. And in fact, they're working potentially on a booster shot about some of the strains that we've been talking about. Actually, I'm going to stop for a second and talk about the two strains before I answer the rest of the questions. The one strain from England, basically, the vaccines have been tested against, at least on the bench and in the lab, and both Moderna and Pfizer say no problem. The current mutations, which by the way are occurring in the spike protein, that's the protein that latches onto your cell, are still not a problem and create antibodies against it. What about the one from South Africa? That's a bit more problematic. The testing that's been done, Pfizer said no problem. Moderna said it decreases the antibody response by about 6-fold. However, the response still is sufficient to give you the protection you need. So far, so good. But what Moderna is doing right now is in fact working on a booster shot, which in fact can re-engineer the mRNA to react to the mutation. So they're just doing that for looking ahead prophylactically, if you will. How do I manage the side effects from how long after I get the vaccine am I immune? The data is showing at least probably 8 months. Moderna says a year. We'll know more as we go out in terms of time. This is a time-related issue, obviously. Some vaccines give you immunity almost for life, like measles or polio. Others need to be repeated on an annual basis, like influenza, but that really is related to the fact that the influenza is built off of the actual virus itself. This is a different story, so we don't really know quite sure, but we think it's going to be very long. How do I manage the side effects from the vaccine shot? Most side effects are pretty minimal. It's some swelling, some pain. It could be a fever and some fatigue. Most of it's been lasting about 24 hours. Obviously, you can put some ice on the area if it's bothering you enough, and you can use Tylenol or ibuprofen. If it lasts beyond 24 hours, then you should check with your physician. Can the vaccines be mixed? No, they should not be mixed at this point, except if it's under extremely extenuating circumstances, meaning you could never get a second shot with the same vaccine, which should be highly unlikely. Can I have the next slide, please? Can the second shot be delayed? Again, Pfizer is 3 weeks, Moderna is 4 weeks for the second shot. Now people in this country are saying 6 weeks. It's probably okay, but there's no scientific evidence to back that up completely. UK has gone to 12 weeks. The doctors are rising up against that and feel that's dangerous because we don't know how your immune response will react to a booster that's delayed that long. But, you know, if you miss it by a week or two, I don't think there's any significant issue. And that's why I think we're talking about 6 weeks. But it would be nice if we can get it on time. Is one vaccine preferable to another? Moderna and Pfizer, which are the two that are available now, essentially have the same efficacy. It would be nice if, in fact, on a one-shot basis, J&J comes along with the same efficacy also. Again, how long the immunity lasts, we talked about that. Is the vaccine effective against a mutated virus? I think we talked about that. What are the age limits for the vaccines? Pfizer is 16 and up. Moderna is 18 and up. And I understand now they're both working on vaccines to go from 5 to the base age for the adult vaccine. Does the vaccine affect the evaluation for possible COVID? No, it doesn't, because again, the PCR test is measuring the RNA and certain RNA or DNA or RNA actually in the virus cell itself. So again, this is just the messenger RNA. It's different, so it won't affect an evaluation. And do we know about the vaccine's long-term safety? I had mentioned before that in all the history of creating vaccines, almost all side effects occur within 2 months. And that's why we waited at least 2 months to look at the phase 3 studies because of looking at some, for lack of a better term, quote unquote, long-term safety. So Danielle, I think I'm going to stop there and let other people talk about the logistics of this, and then I'll stay around to answer any questions if anybody has any. Okay?
All right. Perfect. Thank you very much, Dr. Deutsch. We appreciate it. I believe Annette is going to go next.
Yeah, sure. Hi, everyone. So now we're going to just provide some information around the vaccine rollout across the state, eligibility for the vaccine, and then information on consent and post-vaccine information. So New York State is using a phased approach for prioritizing people based on eligibility for the COVID vaccine. People living in OPWDD residences are part of the 1A group, and they are being supported by the residential providers, and they are working with you or your family member or your representative for consent to get the vaccine. For those members in the community, the vaccine has started to roll out to prioritize groups based on need and risk. And this has been a constantly evolving situation as the distribution continues. So for updated information on the state's rollout plan for the vaccine, you can go to the site that's listed here, covid19vaccine.health.ny.gov, for up-to-date information. Next. So New York State has a website to help people determine if they are eligible. You can complete a brief survey to determine eligibility. Right now, in addition to those living in certified residential settings, people who are 65 and older and persons who work in certain public-facing essential positions are able to get the vaccine. but you can complete the survey to see if you are eligible on this link that's listed here, the Am I Eligible link. So to make appointments for the vaccine, there are two options. You have the online option or by phone. For the online option, from the eligibility survey, if you are determined to be eligible for the vaccine, you'll see a message that states that you're eligible to get the vaccine, and it will also give you options to view providers in your area and instructions on how to schedule for the vaccine. Some of the providers are scheduling by phone and online as well, and the information will be displayed as you search for the provider. What we are seeing is that some providers have all of their appointments booked. So you may want to go back and check with the provider at a later time, or check for other providers, or look for updates on the website to see if additional appointments become available. You can also make an appointment by phone. The COVID-19 vaccine hotline is open from 7 a.m. to 10 p.m., 7 days a week. And the number is listed here, 1-833-697-4829. Next. So just some tips for scheduling. We know that both the hotline and the websites have had a lot of traffic, and they're experiencing very high volume. So if you are getting error messages or busy signals, or if you are on hold for a long time, you may want to access the call center or check the website either earlier in the morning or later in the evening when the sites are less busy. You can also reach out to your primary care provider to find out if they're going to be getting vaccines and what the process will be to get a vaccine through your primary care provider. We also want to mention that care managers can assist in the process if needed, but it's important to note that some scheduling sites ask medical questions that are best answered by you or your family member or your primary support person. But if you or your primary caregiver needs assistance, or if you do not have a support person to assist you, please reach out to your care manager. Your care manager can schedule the appointment together with you through teleconference or through video conference. So if you want more information on the type of screening questions that are being asked, you can go to this link that's here, and this link is to the screening checklist information for healthcare providers. So back to you, Danielle.
Thank you, Annette. And next we're going to have Diane go through some of the information with you. Diane.
Hi, thanks, Danielle.
Well,
so one of the other important things that we want everybody to be aware of is that when you are getting the COVID-19 vaccine, you do need to sign an informed consent. The consent that is required is something that's been confirmed by the New York State Department of Health. And it's been also confirmed that there is consent that's needed to receive both the first and the second dose of the COVID-19 vaccine. So even if you've consented to the first dose, you will need to sign a second consent form to give consent for the second dose. One consent won't cover both doses. Important, for those of you on the line to know is that for individuals that we recognize may not have the ability to consent on their own to the vaccine, that there are other options. So in terms of the consent itself for the vaccine, it can be provided, of course, by the individual getting the vaccine if they do have the capacity to do that. But if not, consent can be given by people who really have the ability to do that, as is written in the law. And what that really means is that if the person who is getting the vaccine doesn't have capacity to consent on their own, a legal guardian can do that for them if they have a legal guardian. And if not, there's sort of a list that goes in a priority order of actively involved family members that can consent on the individual's behalf. Something important to point out, I don't know that it's come up specifically either as a concern or any kind of question, but we do want to point out for those, anyone on the line who may have loved ones who live in a residential setting, in a group home or ICF, the residents, although they're assisting with making those appointments, they cannot consent on behalf of the individual. If you, as the family member, are the decision maker for your loved one, you'll be the one that would make that decision and would need to consent because, of course, that's your role and your right to do so. For those of you who might want to see what the consent form looks like, we do have a link here in the slide. And this slide presentation, I believe, is also up on our website, and some of these individual links are as well on both the PHP and CareDesign website. So if you wanted to take a look at the consent form, you can use that link and become familiar with what that looks like. Next slide. So in terms of care manager's role in the informed consent, we want to make sure that everyone knows that there is no need for you to provide a copy of that consent to your care manager. The care managers do not need that. The consent form is really something that is completed between the person getting the vaccine and the provider of the vaccine, the person administering or the provider administering the vaccine. Your care manager can absolutely provide you with educational materials if you need them to be able to make that informed decision and to help you determine if you or who can provide consent for the person to get the vaccine. And they can also help you to complete the form if you need to do that. But the care manager does not need a copy of the informed consent. And then we also just wanted to let you know about some things about what occurs after you get the vaccine. So after you get the vaccine, anyone who gets the vaccine will get a card, a vaccination card, showing that you received the vaccine. That card will also include a place where you can record your next appointment for the second dose, which we definitely recommend doing if you have an appointment made. But in addition to that card, the CDC has developed what's called a V-Safe program. It's really a health checker to take place after the vaccine. If you, the program is something that can be used for those individuals who have a smartphone, and it uses text messages and some web surveys to be able to check in with you after you've had the COVID-19 vaccine. So through that V-Safe program, if you're not feeling well, if you're having any side effects from the COVID vaccine, that's a way that you can communicate back. And depending on the answers that you give, you may get a call from someone at the CDC to check on you and also to get some more information. And then finally, another benefit from the V-Safe program is that if you're registered for that, it will remind you to get your second COVID-19 vaccine dose when it's time to do that. So again, down at the bottom of that slide, which again will be available up on the website. Thanks, Carlene, for going back to that. There is a link there if you wanted to see what that looks like, and that's the link that you would use to register for the V-Safe program after you've received the vaccine, if you'd like to do that. Okay. And then we just wanted to remind everybody on the call, I think Dr. Deutsch spoke to this really well. You know, we don't know what, you know, we certainly should not expect that after receiving the vaccine that it means that we no longer need to be safe. I think we need to just really be diligent. I was listening to the news this morning, and I think that, you know, really what we're saying is we probably need to be expecting to do these things throughout 2021 to really make sure that we're continuing to really try to hamper the spread of the virus. And these are just, you know, reminders on the things that you need to do to stay safe. Practice social distancing, wash your hands often, make sure you're wearing a mask in public. Of course, don't go out if you're not feeling well, and just take care of yourself overall to be best protected should you be exposed to the virus. So those are just important reminders. And thanks, Danielle. I think that wraps us up and we can move on to questions.
Great. Thank you guys very much. There have been some questions that have come into the chat for Dr. Deutsch, and I believe some of these are also care management questions. So I'm just going to go through. The first question from Sonia is, how many days after the first vaccine do you have some protection? Is it the same for both vaccines here in the U.S.?
Good question. That's a little bit variable. Some people think, or a lot of people think, within about 2 weeks after the first shot. And then within about after the second shot to get to 95%, somewhere around, again, 2 to 3 weeks.
Okay, thank you.
But remember, in both vaccines, after you get the first shot, you're only somewhere around 50 to 60%, somewhere in that range in terms of protected. So you still need to be very cautious.
Okay, thank you. One of the members had asked, what can you tell us about the Johnson & Johnson vaccine? I joined late. Obviously, if you mentioned it, that they can look at the recording later, but you did speak to that, and I know you mentioned that it would be a one vaccine for that one. I don't know if you want to just touch on that.
Sure. The Johnson & Johnson vaccine is a vaccine that uses a DNA that makes messenger RNA, and the carrier, instead of a lipid nanoprotein, is actually a harmless virus. So they are injecting a virus in, but it is nothing, it can't infect you in any which way. And right now, they've just done all their trials and everything with one dose, and it seems to be significantly effective. But it's still a wait and see. We need to see what the efficacy is after they open up the data from the phase 3 trial, which I think they're going to be doing in the next week or two to present to the FDA for emergency approval. It would be very much a game changer to have a third vaccine, which is only one shot.
Okay. Thank you. We do have a question from Susan, who is asking, for individuals with developmental disabilities, has anyone following this population when they get vaccines to see if they have more severe reaction to the vaccines, and any follow-up on these individuals in group homes or congregate settings?
Again, a very good question, a very thoughtful question. I'm not sure I can give you any kind of answer because the logistics on this are still somewhat, early on in the game as to how many people with IDD have gotten the vaccines. And I'm not sure how many of those people have been signed up through a residence or through their guardian or caregiver for the V-Safe program. And even if they are signed up for the V-Safe program, does that program know that they have IDD? The V-Safe program, by the way, is a program that you can volunteer to sign up with after you get your shot, which is from the CDC. They send you text messages periodically to find out how you're doing, if you've had any side effects, et cetera. So I'm not sure there's any data on that yet. I haven't heard of anything in dealing with our members. We do clinical rounds of anybody who's in the hospital or any other facility on a weekly basis, and I've not heard of any issues related to the vaccine at this point.
Okay, thank you. This question might be for Diane. In regards to question 2 of the consent form, if you answer yes, are you precluded from getting the vaccine, and are participants in group home settings showing photo ID when receiving the vaccine?
Thanks, Danielle. So, I did pull up the consent form. There were a couple different versions of the consent form, and I didn't see the questions numbered. So just for clarification, it looks like question 2 is referring to a question about allergies, asking if there are any allergies to medication, so on and so forth. So far as I know, filling out that question and answering yes to that on the consent form, or to some of the screening questions that I think also come up on some of the websites, would not preclude someone from getting the vaccine. However, I'm also aware that when you go and have the vaccine, the person administering the vaccine will review all of those questions again. And certainly at that point, if there was a question about any kind of severe allergy, that would be the situation where I would imagine as Dr. Deutsch referenced, they would watch more closely or for a longer period after the vaccine to ensure that there's not a reaction. If that was not the question that you were referencing, please just type into the chat to let me know so that we can answer that better. The other question regarding whether participants in group homes are showing photo ID when they receive the vaccine, that is a great question. I do not believe that that a photo ID has been a requirement for people living in group homes. If there are others on the call who've heard differently, you can say so. I do know that there are requirements for people in other certain groups. So individuals who live in, individuals who are qualifying because of their age need to be able to show an identification that would show their proof of age. And if you are qualifying because you work in one of those public facing jobs, you have to show some proof of that. I have not heard specifics. Annette, do you know on how distributors are verifying that someone lives in a group home?
Yes, what I can add to that is many of the residential providers have links through the Department of Health to the vaccinating providers. So some of the clinics or hospital settings or any of those external providers that are going to help give the vaccine in the congregate settings. So they are making the appointments directly with those providers. Also, many of the residential providers have developed partnerships with long-term care pharmacies, and they're having the pharmacies come in. So that is the way the majority of people who live in residential settings have been getting the vaccine. So the ID situation hasn't really been much of a problem from the calls that I've been on.
Thank you. And Diane, I can't see who wrote the question because it's listed as guest, but they did say for question 2, it's actually asking in the last 10 days, have they been tested for COVID or been told to quarantine at home to an exposure to COVID?
Thanks, Danielle. I did see that too. And I apologize to whoever asked that question. I for whatever reason, the consent form that I accessed did not have that same list of questions. I'm actually going to defer that to Dr. Deutsch. I'm not sure of the answer to that question of whether that would preclude someone from getting the vaccine or how that would be handled if you answered yes to that question.
Yeah, thanks, Diane. The answer is the direction is you want to wait until, if you have COVID, you want to wait until it's resolved. And as I said, if you get specific treatments, wait 90 days. If you don't get specific treatments, once you've gotten negative tests, it's okay. If you're isolating, what that means is you don't know if you have COVID yet. And so it sort of falls into the realm of assuming you have COVID until proven otherwise.
Okay. Thank you for that clarification. And then another question that we have from, let me just see, from Carol is, if you receive the shingles vaccine, how long do you need to wait until you can get the COVID vaccine?
That's that's an interesting question. I'm not sure I can answer that with any scientific evidence. I don't know how long ago you've gotten the shingles vaccine, but basically, again, I don't think there's going to be a problem. I don't think there's any particular time to wait. I would probably wait at least maybe 30 days after you got the other shot, but particularly if it's your second dose.
Okay, thank you. And then there was a question regarding reactions. Are they finding more reactions after the second dose as compared to the first dose, specifically in relation to people who have had COVID?
I can answer that in 2 parts. The answer to the first part is, yeah, there seems to be a higher incidence of local reactions after the second dose. And that may be a good sign that your body's acting even more vigorously because it's got some immunity now and it's starting to pour out antibodies very quickly against that booster shot. So yes, people do report, or the reports have been that there's more of a reaction after the second dose. If you're going to have a reaction, some people don't have any reaction at all. I don't think there's any information that breaks down whether or not the reaction is more severe as to whether you've had COVID or not.
Thank you. I don't see any more questions in the chat, but we do have people that are on the phone. So what I want to do is if you have a question and you're on the phone, if you can use *6 to unmute and then the *6 to mute again. But if somebody is on the phone and would like to ask a question, please unmute.
I have a question and I'm on the phone.
Hi, yep, you can go ahead.
Hi, I'm calling my question is, I've looked at all of the various websites that have been listed by CareDesign. My brother is 59, has a history of heart disease and has a defibrillator implanted. He is OPWDD, but I don't see any way to even get him on any type of waiting list for a vaccine.
Well, I'll start. Unfortunately, not being in a residence, if he's in the community, he is falling into one of the categories. And right now, at least around the country, there's a huge amount of frustration for people who are either 65 and older, 75 and older, or if he fits into, which he may, into the group 1B with high risk. Those people are still having problems also. I mean, right now, the bottom line is we just don't have enough vaccine. There's more demand than there is vaccine. So it sounds to me like, and I'll defer to Diane and other people who talked about the logistics as to whether or not, there are any other pathways for somebody who is involved with OPWDD who's high risk as opposed to somebody who's high risk that's not.
Thanks, Dr. Deutsch. It's Diane, and I'll take that. And I agree with everything Dr. Deutsch said. Unfortunately, the determinations of how priority groups were set up was set up at the state level based on what they know about how much vaccine they have available and using whatever information they've used to determine what they think was the best rollout. So at this point, if your brother, it sounds like, but if I'm incorrect, you can let me know. But if he does not live in a group home setting, it sounds like he's not eligible yet for the vaccine, and there's not waiting lists. What I can tell you is a couple things. I know that CareDesign and PHP and really the whole provider community as a whole, working with and supporting people with developmental disabilities, have continued and will continue to advocate to the state that we feel that this group needs to be prioritized to have the vaccine. So we are continuing with those advocacy efforts. The other thing is that we are committed to keeping families informed so that as soon as we have updates on other priority groups being included, that we will be doing outreach to let you know and keeping you updated about the best way that you can conduct the vaccine. I wish that I had, more information than that to be able to assist. I don't know if there's anybody else on the call that feels I missed anything, Annette or others, but that's the best information that we can provide at this time that I know.
I just want to ask a question. So you are saying that there is no wait list at this point. You are correct. He does not live in a congregate setting. There isn't even a wait list that I can get on for when they do open this up.
Correct. That's my understanding. The only thing, aside from the information that we presented on the websites, and I think Annette mentioned this, but I don't know that it's clearly on there, is to also contact your brother's, physician, because if they are able to get vaccine supply, which may happen with some doctors' offices, that may be a way to have him on a list with his own provider. So that would be the best advice.
I did that. My brother actually wants to ask you a quick question.
A quick question. Is it variable from state? My quick question is this thing variable from state to state?
Are the rules vary from state to state?
Yeah, we are seeing that a little. I mean, It's not so much that the rules are different, but the way they have opened up their priority lists have been different. So I know, for example, in New Jersey right now, people who are 16 to 64 with underlying conditions, they have been added to the 1B priority group. New York just hasn't opened up the list yet to people with underlying conditions. And Connecticut also, has done something a little bit different. So it has varied from state to state.
All right, thank you. And I see there is another question in the chat. We'll get to that, but then we really do need to wrap up just because we're coming towards the end of the meeting. And somebody was just asking in regards to 3 staff who tested positive in a residential setting. 2 quarantines were 10 days. Middle one was 2 weeks. Is there a rule of thumb on length of time for quarantine?
Danielle, I can answer that.
Okay, go ahead.
I'll answer it pretty quickly. There actually has been information pushed out on a very routine basis from OPWDD, and that's the guidance that the group homes have to follow. So I'm not exactly sure what the circumstances are on why one was 2 weeks and one were 10 days. My guess is that it had something to do. I mean, you're saying without symptoms, so I don't know exactly, but there are, there's clear guidelines, and those are accessible to anybody who wants to take a look at them on the OPWDD site. So that's what the residential facilities are required to follow for quarantines.
Thank you, Diane. And then we just have one more quick question and then we'll wrap up the meeting. How long are they finding antibodies in people who have had COVID?
Again, they're finding them fairly long term. At the beginning, we thought it's not so much antibodies. I don't want to get confuse people, but the antibodies, again, are the proteins that, fight off the virus. But there are other things in your immune system. And even though antibodies may dwindle over time because they're produced in a reaction, there are B cells which produce them. And there are T cells, which are called memory cells and also help fight the virus. Even though antibody levels may dwindle, the B cells and the T cells are sort of in the background. And we're really not measuring those unless you get very sophisticated in the laboratory. But people have gotten sophisticated in showing that those cells, which in fact will react if the virus comes along again to bump up the amount of antibodies, are holding steady. And so it looks like right now, a fairly long time. We thought at the beginning it was going to dwindle over 30 days. It looks like it's lasting 6 to 8 months at least.
Great. All right. Thank you, Dr. Deutsch, for that follow-up. So we're at the end of the meeting. So I just want to, Carlene is sharing a screen, and we want to thank everybody from Care Design and PHP, and Dr. Deutsch and Annette and Diane and Carlene for helping out with the meeting today. And you'll see up on the website, we have the PHP website as well as the Care Design website. And as we mentioned, this discussion will be posted on the website. And then you'll also see the links for registering for events for both PHP and Care Design. So I want to thank everybody for joining us. We hope you found this information helpful, and we hope everybody stays safe. Thank you.